So today's class, I think we'll be taking on DVT from the perspective of IR. And again, as we had taken up the previous class on, varicocele, the prostate artery embolization, DVT treatment is also something uh, uh, an IR can manage, everything on his own, unless, of course, the patient has comorbidities and is severely sick. But standalone DVT case is something that anything that is there to do for that patient, you can kind of do it. So it's a common pathology we all know, and there is a 2 million new cases of DVT. The biggest thing that we also need to understand is its pathology is often not known. Sometimes it is an hematological issue, sometimes it's provoked, unprovoked. And then whether there is any underlying anatomical lesion as well, there is some compression which is leading to decrease in the blood flow and stagnation leading to deep vein thrombosis. So one of those most common underlying anatomical lesion is May-Thurner syndrome, which we will be discussing, and what we can do to make sure that recurrence of DVT is taken care of. So we all know the Virchow's triad of thrombosis, and it requires stasis of blood, a bit of endothelial injury, and alterations in the constituents of the blood. Right. So alternation in the constituents of the blood will include any thrombophilias like factor V laden, antithrombin 3 deficiency, protein C, protein S. Those things we have all read this thing in the pathology part of our MBBS. So this is something that you must remember, and always try to make sure that we can, whatever is the inciting issue, whatever is the problem, is taken care of in all three areas. The vascular injury, what to do about it, and whether there is a differential blood composition, then you might have to keep anticoagulation lifelong. And if there is alteration in blood flow stasis, then mobilization, physiotherapy, those things are important to prevent a secondary episode. So what happens is, we have to divide the DVT on the basis of course, acute and chronic. Right now, I'm talking more about acute DVT. Then we divide it on the basis of location, that is proximal DVT and distal DVT. Of course, when there is proximal DVT, you might have distal DVT as well. So distal here would be like smaller veins, calf veins below the knee. Once it goes above knee, like it involves femoral vein or iliac veins, then it starts being considered as a um proximal DVT. So proximal DVT is more of an issue because the bigger veins have a lot more thrombus burden. It can go up. Also, the collaterals as you go up become difficult, and later on, if the initial DVT is not nicely treated, significant anticoagulation, or if required, thrombectomy is not done, the chances of post-thrombotic syndrome, what we'll discuss later, or chronic DVT, which is symptomatic, is much more in proximal DVT as compared to isolated distal DVT. Second part is again, as I said, unprovoked or provoked. Provoked DVT is like patient had a surgery, patient had some morbid illness, patient was immobilized. So we know there was some inciting factor which is now gone. So you don't expect the patient to have DVT in the later years. But unprovoked means patient was just fine, there was no issue, and still suddenly one day he had DVT. Now those are more related to inherited thrombophilias, and we need to do the workup for that. So this is the risk factors, that this is the thrombophilia workup that we usually send. Of course, even this is not 100%. Around 60-70% of the patients only have this. Rest have other mutations which we don't do. So of course, in those cases, we give a trial of stopping, and if there is a second episode, then we make sure we keep the patient on anticoagulation lifelong. So factor V laden, prothrombin, protein C, protein S, and antithrombin deficiency. These are five thrombophilias which are tested in a thrombophilia package. And then other risk factors, including malignancy leading to thrombophilia, presence of a catheter which is inducing thrombosis, trauma, surgery, immobilization, pregnancy and oral contraceptives or HRT, which is hormone replacement therapy, cancer therapies, including certain drugs which cause, so drug-induced thrombophilia, heart failure and congenital heart disease have increased risk of thrombophilia. Then antiphospholipid syndrome, APLA, we all know about, polycythemia vera and ET, which are hyperthrombosis, cause hyperthrombosis. So these are the nephrotic syndrome because there is loss of these protein C and protein S in nephrotic syndrome. So these are various other risk factors which you must see before we label something as provoked or unprovoked. The next part is, what are the anatomical causes? The most common anatomical issue is May-Thurner syndrome, which is compression of the vein by a arterial system. So mostly the most common May-Thurner syndrome is the compression of the left iliac vein by the right iliac artery, or it could be previous DVT or it could be extrinsic compression by a tumor. So these are few common anatomical factors. Very rarely it can be by RP fibrosis, aortic aneurysms, old radiation, pelvic radiation for some pelvic cancer causing radiation-induced stenosis of the iliac veins. And sometimes, catheterization, femoral catheterizations, which have been there for a long time. And if left inside, can sometimes, induce thrombosis in that area. Of course, the initial presentation can be including limb swelling, acute onset with significant edema, pain, erythema, warmth, and very severe forms are something called phlegmasia ceruleus dolens, which is, like is leg threatening sometimes because there is severe obstruction of the venous outflow and the leg starts becoming blue and loss of sensation. And those are the forms which you really need to do something aggressively because even if the patient doesn't have any other issue, if that kind of leg is developing, we need to push the patient for thrombectomy. Of course, pulmonary embolism can be initial presentation itself because DVT is one of the most common causes of PE. And chest pain, breathlessness, hemoptysis, dizziness, these are symptoms of PE which can be induced because there was a DVT and there is now embolism. Of course, D-dimer is elevated in all patients of acute DVT. Symptoms, second part is post-thrombotic syndrome. These are symptoms of acute DVT. Then there are symptoms of PTS. PTS is basically chronic DVT. That patient had DVT, was an anticoagulation, the initial thrombosis is taken care of, but those veins have now become a problem and or the valves have got destroyed because of the thrombosis. So the blood is not being able to pushed up back to the heart and it stays in the leg. So there is stasis which leads to edema, which leads to pain, varicosities, hyperpigmentation, subcutaneous fibrosis. This is like a similar picture as varicose veins because in that also the same thing happens. The valves are defective. Here it is because of old DVT, either there is obstruction or the valves have become destroyed by chronic thrombosis. Of course, treatment is different. There we close down the superficial venous system, whereas here we can't do that because already deep venous system is significantly affected. So here we try to open the deep veins. So what is the imaging? Of course, non-invasive imaging includes ultrasound, very good, simple technique of seeing DVT. Acute DVT will have non-compressibility and venous distension actually, whereas chronic DVT is the lumen is small, hypoechoic thrombus, loss of Doppler flow, loss of physicity, loss of augmentation on Valsalva. So all those things will be there in this we all know in ultrasound. So, compressing, no compression, we can see that it is not significantly shutting down, otherwise the vein should totally collapse. This is actually expanded vein in acute, but no color flow. This is how you see the case in acute DVT. Then evaluation of the inferior vena cava and all if required. What is the extent? Often where are fatty patients and the iliac area is, you can't really see the iliac veins. So you need a CT. You need to rule out May-Thurner anatomy. You need to rule out any extrinsic compression. And of course, sometimes we combine it with a CTPA or pulmonary angio to make sure that DVT is also not there if the patient is a little sick. The next thing, this is the CT you see here. The thrombus is extending. This is the bifurcation of the vein. This is the IVC. This is the right. Okay, my pointer is not on. Sorry. Yeah. So this is the artery. This is the vein. This is down here, the right iliac vein coming into the IVC. This is the left iliac.